Hi, good evening, everyone. Welcome to the first ESGE webinar of 2022. So this is the fifth consecutive year that the ESGE has produced webinars showcasing hot topics for you, the audience. So the webinar tonight is entitled, So You Want to Be Trained in Metabolic/Bariatric Endoscopy? I'm Tony Tham. I'm a gastroenterologist from Belfast in Northern Ireland. I'm also the chair of the curricula working group and a member of the governing board of the ESGE. So the ESGE has produced several advanced endoscopy curricula, such as ESD, ERCPs, for example, to fill an unmet need in Europe because there are no such curricula in existence at present. There are curricula on OGDs and colonoscopies, but not in advanced endoscopy. So the broad aim of such curricula is to try to answer the important questions. How do you train somebody to be competent? And how do you know they are competent? So let's turn to bariatric endoscopy. So this area can be divided into two main themes or competencies. How do you perform that bariatric therapy? And the other main competencies, how do you manage complications arising as a result of bariatric surgery? So the ESGE are about to publish the curricula on bariatric endoscopy, and this webinar is therefore a sneak preview of what is going to be in the curriculum. So let's go to the first slide. So a few housekeeping rules. Please use the Q&A box to submit your questions. We would love to hear from you, and we look forward to a lively question and answer session after the two talks. So you will receive CME credit for attending this webinar, 1 credit. So it gives me great pleasure to introduce our first speaker of the evening, Ivo Boskoski from the Catholic University of Rome. So Ivo is the task force leader of the ESGE Bariatric Endoscopy Curriculum Task Force. Ivo did his PhD on endoscopic treatment of obesity, and is a faculty of the European Endoscopy Training Center. So apart from his many endoscopic skills, he is also a published novelist. So I can't think of anybody better to tell us how one can learn to perform therapeutic bariatric endoscopy. So over to you, Ivo.
Thank you, Tony. Thank you, everybody, for being here this evening. So I will go straight forward to the topic. So you're here probably because you want to learn to perform therapeutic bariatric endoscopy. So these are my disclosures. Obesity is a chronic, relapsing, multifactorial disease and is increasing worldwide. When we talk about obesity, there are different types of obesity, and what endoscopy is aiming to treat is always about BMI for patients from 30 to 40. And of course, there can be many other indications for more than 40, people that refuse surgery, not fit for surgery, and so on. Of course, this is our best target of patients. And if you see patients going literally to surgery are less than 2% with sleeve gastrectomy or bypass or SADIES or other treatments. Also here, there are some indications, but this is not the topic of this talk this evening. What is very concerning is this. You see, for the first time in 2022, obese children will outnumber the underweight. And this is really scaring, and we really need to do something. So from endoscopical point of view, this is the evolution of endoscopy from open surgery to laparoscopic to the nodes one. I'm also gastroenterologist like many of you, but we do a lot of operative endoscopy, a lot of novel techniques. And many procedures have been taken from surgery. Now we do many things in an endoscopy. And the brand new one is this one that you see here is robotic endoscopy. We are doing this into a trial, and it's a completely robotic device that sutures the stomach. So this means that there is a lot of interest in the field, and a lot of requests and a lot of people to treat. So why bariatric procedures are different from all other endoscopic techniques? So if we talk about ERCP, there is a patient with a stone or with a cancer, we remove the stone, we place a stent, or we do ultrasound and so on. We can follow up the patient, we remove a polyp. But obesity is different thing. Here we are talking about chronic relapsing multifactorial disease, and the patient needs to be evaluated by many specialists. So it is not only us giving indication. So just in the past 9 years, there have been about 500 publications. So it means that it's a hot topic and very interesting field. And today we know exactly that bariatric endoscopy is repeatable, totally or partially reversible. It treats obesity and related diseases, has less than 1% of adverse events, and is well tolerated and accepted. So you want to be trained in bariatric endoscopy. So ESGE is there to give the answer. We have created in ESGE curricula, international working group with 16 experts in bariatric endoscopy. And we had agreement after 3 voting rounds. We divided the treatments in level 1 and level 2. Level 1 are balloons and gastric aspiration. Level 2, suturings, all kinds of suturings. You can see overstitch and dominant pose, duodenal mucosal resurfacing, bypasses, and so on. Before starting, of course, ESGE recommends that bariatric endoscopy of any level, the endoscopy should have achieved previous competency in upper GI, at least 300 gastroscopies, plus meeting the ESGE quality measures for upper GI endoscopy. And for level 2, additional formal training could be required, like fluoroscopic wireless maneuvering and so on. Of course, trainees should know all types of altered anatomy, especially in bariatric surgery, if you need to treat complications. After that, Roberta will talk about this. And of course, any kind of altered anatomy in surgery, basic understanding of physiology and pathophysiology of energy, metabolism, gut hormones, obesity-related GI conditions, and so on. Body fat types is very important. And this is about basic. You should not be experts in this, but you should know how these things work. Basic knowledge of cited mechanisms of absorption of vitamins and lifestyle changes. You should not give dietary plans to the patients. There is the nutrition, there is the psychologist, bariatric surgeon, and so on. You should be able to case discuss the patients in the MDTs, and you should know the available devices and to apply what you have to the patient. So for level 1 procedures, ESGE recommends that endoscopy is competent in gastric balloon placements with adequate experience in therapeutic endoscopy, can be considered also competent to manage complications secondary to this. It is the same for aspiration devices. If you have adequate experience in that, you can be considered competent to manage complications in these cases. For level 2, these are only some of the procedures. Trainees with adequate experience in therapeutic conventional endoscopy and competence in endoscopic suturing or gas applications can be considered competent for the management of complications during the procedures or just afterwards. This is the same for all kinds of duodenal sleeves. Why? If you go directly on suturing and you are not competent, and if you have this situation here, this is a patient that 4 days after endoscopic sleeve gastroplasty vomited blood, and when we did gastroscopy, there was very big clots inside, and still the patient bleeded and so on. So you should be an expert in these. You see here 2 clips were placed on the site of the bleeding, and the situation was recovered. But this can happen. This can happen during the procedure. You can have perforations and so on with any kind of a device. Of course, turns of the helix device, ring, the overstitch procedure should be done in a certain manner. So this is why training is very more important. You're probably asking yourself how many procedures we need to do before becoming competent. Most trainees should perform more than 20 ESG procedures and 10 gastric balloons placement. This is just an example. For the competence. So these numbers might not always be sufficient marker of experience and competence. And of course, these recommendations are only some of those that will be reported in the paper. These are only the highlighted ones. So you have to place at least 10 intragastric balloon and remove them during your training. You need to implant at least 10 aspirating devices. Before starting the treatment with aspiration therapy or the basic PECs, and at least 20 ESG procedures with the same device should be done during the training. So if you switch from one to another device, these numbers doesn't count. What about endoscopic revision of the bypass? At least 5 endoscopic reductions for those that have competence for with ESG, or 20 endoscopic reductions for those without competence. DMR and duodenal sleeves. The DMR is duodenal mucosal rejuvenation. For these procedures, these are not widely available, but if are going to be done, then 10 such procedures should be done during the training. Where to train? Bariatric centers with multidisciplinary teams for evaluation of patients and availability of simulators and teaching programs. What MDT means? That means that you have the bariatric surgeon, you have the radiologists, interventional radiologists, and so on. So if you have a problem like perforation or things that you cannot manage alone, even after the procedure, you're in trouble. So you should be inside the teams, and you should collaborate with these kind of colleagues. So the multidisciplinary team is on the basis for the training. So which learning methods? Of course, we do not have mechanical simulators currently for this kind of treatments. Ex vivo simulation should be the first choice. Mechanical simulators are not available. Generally, trainees learn the technical skills and technical aspects, assembling, placement, removal, and so on in web labs or dry labs. In the clinical setting, the training should be done under direct supervision of an expert endoscopist. This is the master experience model on-job training, receiving immediate feedback. Then in dry labs, you can try the device, you can try how needles perform, how the device is to feel the haptic feedback, and so on. For how long to train? Minimum training period on ex vivo simulators should be established, followed by hand-on training. Trainees should participate on a case or a step in the procedure. So it means that I can give the suturing device to the trainee, let's say the overstitch or whatever else, let the trainee feel the resistances, pull the gastric wall, push the needle, and so on, and then put the first sutures, or let the trainee do the entire procedure during the training. So trainees should access teaching resources, should take part of the MDT of the evaluations of the patients, follow-up visits which are essential, and so on. So also trainings between them, exchanging experience is we have seen it is very important during the training periods. So for how long to train again? The minimum training periods of 1 to 3 months, including at least the minimum number of procedures defined for competence for level 1, and 3 to 6 months for level 2. In case the training is interrupted, longer period or numbers should be required, but this is the same for any kind of training for ERCP, endoscopic ultrasound, and so on. So the quality of trainees, who should be a trainer? Trainees principal trainer should ideally fulfill the following: more than 1 year of experience or 30 procedures per year on independent practice for level 1, and more than 3 years of experience with not less than 50 procedures per year. So these people that perform these numbers for this time should be trainers. self-assessment and independent practice. So trainees should log all cases and their contribution to the cases in their e-portfolio to show acquisition of competence. So once, let's say you have been here, you have learned how to train or in Roberta's place, then you go home, you start doing the procedures, and you should log the number of procedures that you have done. Development of direct observation procedural skills, DOPS, we do not have the DOPS now, but these are for objective assessment of competence, should be pursued. I hope this will be developed very soon. And after independent practice, a minimum period of mandatory practice after competence is required during the independent practice. This includes availability of an expert in the department or on the telephone in the next 6 months. It can happen that you have problems during the suturing, that you don't know how to solve the problem, that during the training you didn't ever encounter that problem. So you can call your trainer or anybody that is expert in the field and to ask for an advice. So there are different types of things and tips that can be found in the literature. The concept is very important, the patient selection, the procedure, and the follow-up. So we are not talking again about any other type of procedure in endoscopy. Obesity is a chronic relapsing multifactorial disease, and you cannot do it alone. You need the MDT, and you should be part of it. So we need more people trained. This is why ESGE promoted this kind of curricula, and this is what you see, the latest news we get. This is why we need people trained and adequately for this kind of procedures.
Thank you very much, Ivo. That was fantastic, and I think it sets the scene very clearly of how somebody should train for such complex procedures, and importantly, so that the patients can be reassured that whoever's doing these procedures has the adequate skill mix and is competent to do so. Just to encourage the audience, please ask your questions via the Q&A chat. We have one question already, so keep them coming. We will have a discussion at the end of the 2 talks. So it gives me great pleasure to introduce our next speaker, Roberta Maselli, who is trained as a surgeon and also in therapeutic endoscopy, and is based at the famous endoscopic unit of Humanitas Research Hospital in Milan. So she's also a member of the ESGE Bariatric Endoscopy Curriculum Task Force, and with her skill sets, she is really well qualified to tell us how to gain expertise in managing complications arising from bariatric surgery. So over to you, Roberta.
Thank you, Tony, and really good evening to everybody. I hope you enjoyed the great lecture of Ivo. And for this lecture, let me say that the situation is even much more complex than with primary bariatric endoscopy, because with complication is understanding how to manage complication and how to gain experience in managing. We have so different type of complication arising from bariatric surgery that, let me say that in our task force, we were 16 experts over there sharing experience and knowledge about this, but not all the time we agree in the same topic. This is my competitive interest disclosure. Let's say that up to now, what we know from our experience or from the literature is that the endoscopic treatment of bariatric surgery complication largely replaces surgical revision that is much more complex, and most of the time comes in emergency. So endoscopy is the first thing that usually they ask for, and we do. And for this, we are able to avoid multiple surgical interventions, especially in those patients that are with very high operating risks. But this is the same slide you have already seen from Ivo. Before starting, really the basics, what we really have to know is crucial, is that the endoscopy should be able to recognize the anatomy related to bariatric endoscopy or bariatric surgery procedure, and also any other surgical altered anatomy. But sometimes we have, this is a pivot competence, but sometimes we have an anatomy that is different from, you know, what we think it should be. So in this case, we should be able to identify specific type based on endoscopic findings. So finally, the endoscopic type findings is the most important things, and we should be able to report and to understand throughout our findings which type of altered anatomy and which type of surgical procedure the patient underwent. For this point of view, we have some papers that are helping us in have a path and to understand differently and specifically for different type of bariatric procedure, what to look for and what to expect to find in the gut during that endoscopy. So, but let's talk specifically in bariatric surgery adverse events. I said specifically, but at the same time, as I was saying at the beginning, there's a lot of different complications that can arise from this type of surgery, that some of that, they are really specific on the type of surgery, or they can be general, like for example, the bleeding or the perforation, that in case can be a leak or a dehiscence of the anastomosis. So depending on the type of bariatric endoscopy, a bariatric surgery already done, we can have different adverse events, and we should know at least the most common of all of them. Why endoscopy? We said at the beginning, because it's fast, is the first thing that they ask for. For example, if you look at this algorithm, when a patient comes that is not stable or unstable, or we should look for infectious status, by finally, even for large leak or small leak, they ask for endoscopy, and depending on what we find in that patient, we should go for one procedure or the other. And just finally, in case there will be a failure of our treatment, the patient will undergo, for example, surgery or something different. So which type of bariatric of endoscopic treatment of adverse events for bariatric surgery we have? Again, a lot coming from internal drainage with pigtails, or the dilation with stricture, with filled balloon, or just placing, it's not just, placing an over the scope clip or normal clips for bleeding or for very small leaks. But here I want to focus on the curriculum, on how to be trained in the management of adverse events. So the key word is competence, and we were focusing on two different aspects. The first one is the definition of competence. Who is competent for this one? And the second thing is how to acquire this competence. So how to be trained to have the acquisition of competence. So focusing on the first, we defined the competent as the ability to independently assess the need for and carry out technically successful and safe procedure in treating complication or adverse events with good patient satisfaction across a range of case difficulties and clinical context. And then it has to be defined the rate at which a trainee should be expected to become competent. So we should talk about numbers. And when we face the number phase, it's not a joke, we really disagree. So still the exact number is not clear. Because the fact is that the treatment requires not only an endoscopic view, because as Ivo was saying, for the primary bariatric procedure, also in gaining competence, we should have the basic competence in pathophysiology of obesity, endocrinology, the nutritional aspect, and also the anesthetic complication. And in this type of patient is crucial, because if the patient comes in emergency, you should understand how to treat it and when and where to ask for anesthesiologists helping you in treating this patient. So we should let's say, talk about pre-training endoscopy skills. That means, for example, learn how to recognize the overall risk associated to endoscopic procedure and also to assess the risk of errors. That means to select the appropriate setting for this type of patient. And then we'll understand to the best selection of patient, procedure, but also devices. Because we have some, again, crucial things, that is the timing of performance of the procedure and also the type of the procedure depending on the type of complication. That means finally altogether to be able to select an appropriate therapy for each type of patient to optimize clinical outcomes. And altogether, we should have the best knowledge possible of the different device that you can use to treat this type of complication. So talking about these pre-training endoscopic skills, that is still not clear the level endoscopic experience that should be enough to undergoing training in bariatric endoscopy management of complication. But at least let's say that trainees should be comfortable in standard upper endoscopy and basic therapeutic techniques, like, for example, the bleeding control. And then when you have something more advanced, if you are also competent in advanced technique, like, for example, US, ERCP or ESD, should be the best, but it's not mandatory. But you should be competent in knowledge of plastic and metal stents, how to place it and remove it, indication, time, and of removal. Because really metal stents are important in treating a lot of type of complication in different adverse events of bariatric surgery. Our main goal was to help people understanding how to get these skills, so how to get these new endoscopy skills in something that is not yet done in the practice. So let's say that the ideal world will be going in a stepwise approach, so going from mechanical simulators to ex vivo models, then animal models, to arrive just later on to the master apprentice model, that is the in vivo, the hands-on model. The fact is that there are no virtual reality mechanical simulators. There is nothing that is able to help us in filling this gap that we have. We can use something that is there. For example, we could use some ex vivo models to simulate a stricture, fistula, and will help us in simulating the treatment with dilation, stenting, septotomy, pigtails. But really not a single model is there for the management of adverse events after bariatric surgery. Like, for example, this one, you can have something like this, but it's not something specific for them. Or you can find, this is another paper reporting this mechanical endoscopic suturing simulator to simulate, for example, in this case, how to perform a pure string with overstitch. But coming back to the master apprentice model, that finally is the hands-on, the in vivo job that we are doing and we are trying to teach to the trainee. So the benefits is that is that on-the-job training, and you can have this immediate feedback from the supervisor. But at the same time, let's say that on the other end, there's some errors, there's potential increasing of patient discomfort because maybe the procedure could be longer, could be more complicated, so we have more risk of complication, so extra procedural time, as it was saying. And most of the time, because it's already a complication, that is a stressful working condition, so it's not really the best condition to teach and to learn at the same time how to manage that type of complication. But the fact is that this type of model give you frequent assessment and feedback that is crucial to assist with the development as expert in bariatric endoscopy and in management of the adverse events. Where exactly, as Ivo already said, at the beginning, we were only talking about these tertiary referral centers. So I'm highlight this sentence. At the same time, what does it mean? I mean that you can have a patient that come back in emergency for a complication of bariatric surgery that is you are not in a referral center, so we'll be able to treat it. Do you have the competence? So after this sentence, we were focusing on the high volume centers that are able to offer sufficient volume of experience for a period that should be 1 to 2 years, so 12 to 24 months, to achieve this competence reliably and include a multidisciplinary meetings and possibly availability of simulators. Of course, if this program is lacking and you don't have this chance, we are encouraging you to go to an externship rotation to achieve this comprehensive training. But till now, we were talking about the management of adverse events after bariatric surgery, but let's focus just for a few slides on the so-called BEC, that is the complication after bariatric endoscopy. Because also in this case, we have very few complications. Ivo was saying less than 1%, that is true, as all the papers already demonstrated, but at the same time, you should be able to treat also this one. And we already said that we have level 1 difficulty. Let's say is a grade of difficulty. In level 1, you have balloons and gastric aspiration, and in level 2, you have all the new complex procedures. So depending, even this case, on what is already done on that patient, we should have different competence level to treat that type of complication, even if the complication are in a very low rate, less than 1%. So I'm coming at the end. So the future perspective is the definition of a number of procedures for each technique for the assessment of competence. We should arrive to have a standardization of the procedure of the learning method will be our future goal. And of course, new technological tools will arrive and we shorten and facilitate this learning curve. And my final thought and conclusion is that, as I was starting and saying at the beginning, the management of adverse events after bariatric surgery is an open challenge, and the endoscopic revisional treatment is gaining more and more importance. But according to impact of endoscopy, definition of competence is becoming mandatory, and it was the goal of this task force I was part of. But the pathway through the building of confidence has to be defined clearly, and this is why we've done all this work for you. Thank you.
Thank you very much, Roberta. That was masterful, and I think it's a reminder that the competencies of an endoscopist skilled in bariatric endoscopy is not just technical, but I think having a knowledge of the pathophysiology of obesity is just so important. So yeah, so we're going to now have the panel Q&A. And there are a few questions that have come in already. So please, if I ask the audience just to keep sending the questions in. So we have a question from Simon Serrato, and this is a really important question. I mean, we've talked about training endoscopists, but as you know, endoscopists are really dependent on our assistants and colleagues, our nurses, the endoscopy nurses. So how do we train the endoscopy nurses?
Ivo, I will try to answer, and then I will see what you think. Yeah. This is a great point, really, because now we are talking only about doctors and how to get the best doctor training possible. But what about nurses? Because even then, we have always, let's say, every day new devices, and even us, we don't know how to use them. You know, we have to check and learn the most benefits of them. But it's the same for nurses. So we are learning together. I think they should have a task force to have a curricula, exactly the same what we have done and what we are trying to do.
Well, we do have these trainings for nurses right now. We also have our event annually. It's called EndoCare. It is dedicated to nurses. We perform procedures with the nurses, but they are the protagonists. And every bariatric procedure is different. So some of those require the nurse really active during the procedures, some less, but the role of the nurse is very important. So we do train nurses right now actively.
Yeah. Thank you. I think it's good to hear that both you, Roberta and Ivo, have not neglected the nurses. That they are part of your program.
They are not
training programs.
mentioned. They're not
Yeah.
mentioned in the curricula because we go step by step. But
Absolutely, and
we'll come there,
that's
as Roberta said, we'll arrive.
Yeah, and it's not in our remit of the curricula anyway. It's for the doctors.
Yeah.
So here's a provocative question for I think maybe for Roberta from Henrik Thoresius. How do you think the surgical community accepts this endoscopic development of bariatric endoscopy?
Ivo, I'll leave it to you because I mean the bariatric and endoscopy adverse events. No, I will reply later.
Well, that is the answer. They need the endoscopies when they have an adverse event. So
yeah, of course. This is why it's not provocative to me. They need us. We are the first one they call. Once the patient is still arriving in the hospital, we are already on call saying he's arriving. What we'll do? The problem is with you.
Yeah, at the end, we are part of the MDT and they are in. So by guidelines, surgically, they cannot treat patients that have certain BMI, and we are treating them. So it's kind of a pact in between. Of course, if I have a patient with 36, 37 of BMI and it is diabetic, of course, I will not promote any kind of endoscopic treatment. I'll send that patient for other kinds of treatments. Or I can try endoscopy because bariatric endoscopy, because it doesn't preclude any further surgical treatment. So we can give a chance to the patient. I mean, we are talking about procedures that are routinely done in 20, 30 minutes, also in propofol, very smoothly, very easy, with less than 1% of adverse events. And most of the patients come for this kind of treatments.
If I can add something, apart from joke, the fact is that with the bariatric surgery all over the world, they are able to treat less than 1% of obesity, of obese patients, because there are much more patients than one can be treated apart from COVID. I mean, because there's a lot of work, so it's not possible to treat all of them. That means that there's a lot of space for everybody. This is why we should be part of a team. Multidisciplinary approach means this one. We are part of the same team, and if they are calling us, as I was joking before, while the patient is still on the way to the hospital because of a complication, they should call us, and we should call them and involve them in the decision process in the selection of the patient. So we should really part of the same team. And I think this is what happened for every type of advanced endoscopic procedure. I can tell the same for achalasia and POEM. So at the beginning, the surgeon went really crazy because they thought that they were taking their patient and they were not doing Heller's myotomy anymore, but it's not the truth. So step by step, we are still at the beginning, let me say. So step by step, we'll find the real dedicated and fine and precise indication for every type of patient. We are still in the phase where there's an overlapping between surgery and endoscopy, but we'll find our way. That maybe, and I think so, probably is a way that we'll do together. It's not a separated way.
That 40 to 50% of our patients come from the bariatric surgeons. They send us the patients.
Yeah, like this.
And I think both of you mentioned the MDT involvement, and I think that's so important, isn't it? Getting all the experts together and everybody recognizing what each other can do, and realizing that you can't do everything and that you have to depend on some other colleague to sort out a particular patient that you can't sort out, for example.
Yeah. The fact is that this is important also from the patient point of view. You know that most of the time, I mean, maybe, I don't know, it's not an exact rate, 95% of the multidisciplinary team in the world is a cancer MDT, no? So the patient feel really comfortable and safe if you tell him the truth, no? I will sit down with all my colleagues, the oncologists, the endoscopists, the radiologists, and all together we'll decide the best treatment for you, for your cancer, to treat your cancer. The fact is that obesity is not an oncological disease. It's considered a benign disease, just, you know, I'm doing something to eat less than usual. Yeah, it's just something mild. Don't think about it. So you don't need an MDT for this one. But in 99% of the time, all the bariatric surgery goes well. You don't have any complication, and the patient in 2 days is at home and is starting losing weight. But in that 1%, once you have complication, you have really the worst complication of your life most of the time. You don't know what to do. And it's difficult to get trained because the rate is less than 1%. So how I can teach somebody to treat less than 1%. Imagine that in my hospital, we are together with Ivo, one of the biggest hospital in Italy for bariatric surgery. They do perform from 12 to 1500 procedure per year. And last year I saw and I treat 3 complications for them. How can I teach somebody with these numbers?
You can't.
And I think another observation about complications as a result of surgery is that a lot of patients that we see in my patch of the world get their bariatric surgery done somewhere else. So it might be done in Belgium, for example, or Turkey, and then they come back and then they develop complications you know, in my patch, and I've no idea what has been done, and I don't have the volume to gain expertise in that. So I think that's a real challenge, isn't it? Patients done in tertiary centers and then going back to their respective countries.
Yeah,
it's a problem.
But even in the same country is the same when the country is big. We have patients coming from 800 kilometers from here, the same at Ivo, so they are coming back home. And you need to have, in this case, maybe it's like a huge MDT. I mean a net that you are in your country and you know who call and to has to do what, because you are guiding them via phone from far.
So we have a couple of technical questions. So maybe start off with you, Ivo, and let me just get this one. What about using overstitch suturing for anastomotic leak in sleeve gastrectomy? Who wants to take that one, Roberta or Ivo?
Can you say it again? I can see
overstitch.
Yep.
For anastomotic leak in sleeve gastrectomy.
Yeah, it's one of the options. So in my presentation, I didn't went for all the options that you can have for this different complication because it won't be too long. It was not the topic and the focus. The fact is that to gain competence in using overstitch to treat a complication, you should before be competent in using overstitch for, let's say, standard indication, because complication is already a complex situation, no? When most of the time you have the patient that is not stable, and there's an infection overgoing, so it's already a complex situation, and you are trying to treat a complex situation with a complex device. So before starting with that one, you should be competent in managing the overstitch for standard indication. Then, of course, is one of the choice depending on the position of the leak. Most of the time for the sleeve gastrectomy is the upper side, but depending on, it's not always after sleeve, and also depending on the size, because you can choose between overstitch or double pigtail stents. So it depends on the situation, but of course is one of the options.
This is the beauty of endoscopy. If you repeat surgery, it's a failure. If you repeat endoscopy, it's not a failure.
Yeah, it is a good point.
Yeah.
And So that again, I think that takes us to maybe another provocative question from Alfredo Ganco, who thinks that when bariatric endoscopy will improve and demonstrate good long-term results, and basically all future bariatric surgeons might become redundant and have to learn endoscopy. So any thoughts from both of you? Are the surgeons going to be hanging up their scalpel?
You have time to retire by then. No, I'm joking. So there always will be place for surgery. I will never think to treat somebody that is really heavy. But we could arrive there. I have treated several patients with more than 65 of BMI, more than 2 times, because ESGE is repeatable. With our overstitch, we have done it after 1 year, after 2 years. If the patient stops losing weight, you can redo it again, and the patient starts losing weight. And I mean, it depends from the patient, but for sure there will be place still for surgery, like now it is for other diseases. Endoscopy cannot do everything. We need the surgeon still.
Yeah, what I can add is ciao to Alfredo. He's my mentor, is the one that really teach me endoscopy. Thank you. Yeah, it's like this. At the same time, you said there will still space for surgery, but with a minimal invasive treatment, let's say in this way, it's not gastroenterology against surgery. It's something in between. It's minimal invasive. So I think that the one that is able to do should do it.
It is symbiosis. It is not a war.
Yeah.
There is also the endoscopic bypass promoted by Marc Berthet. He's doing the gastroenteroanastomosis in pigs. It works very nicely, and he closes the pylorus. And doing after that, you can do the endoscopic sleeve over that, and that's repeatable and reversible at the end.
Yep. So another technical question: is the ESO sponge replacing SAM stent placement in your center?
In Italy, it's not available, the ESO sponge still. So we are waiting for, it's coming. I know that we can buy from other countries nearby. Don't let me say where, but it's not really available, but we know that it's working, and we are just applying the lower endosponge in the esophageal side, and it's working because the vacuum therapy, when you have a collection over there, is always working.
Yeah, it works very nice. Depends how the collection is big and so on.
Yeah.
So there are quite a few questions about recommendations for endoscopy training centers for bariatric endoscopy, and just really to answer the people who've asked these questions in various countries where you're from. So welcome to people dialing in and listening from India and Saudi Arabia and other places. But it's not the role of the ESGE to recommend training centers. So certainly you can ask your trainer or your colleague about possible training centers that they may have come across, and people who have published widely in the area. I think would be a good start. So can I ask both of you, you've mentioned, especially Ivo, that level 2 training in bariatric endoscopy requires knowledge of quite a lot of different kind of techniques.
Yeah.
Do you think that is it acceptable for somebody to be just trained in one technique, or does that risk everything becoming a nail, and if you have just a hammer?
So this depends from the center where it works and how many devices you can have for suturing and for performing these kind of procedures. It's always good to see different techniques, to see how those work, how those perform. This is good for who is in training. I suggest to see at least as much as possible, then to choose one. or to choose the most appropriate that your hospital can allow. But of course, you need to be trained for advanced therapeutic endoscopy, otherwise you can get in trouble. This is a problem.
Okay.
Yeah. The other fact is that one of the reasons why we divide level 1 and level 2, the first reason is that because they are different. So you need different experience and training to be trained in the two levels. But at the same time, is that because one is, let me say, different from the other. I mean that you can be trained and in your center perform just level 1 and not level 2. Or differently is not common, but it should be also the same. So of course you can be a center that do aspiration and different type of balloons. And also about balloons, you are starting placing balloon and you have training for that, but you don't know all the type of balloons. So the best you know, the better, honestly.
Yes, so thank you. So this is a question for Ivo from Altin Heiser. They want to know what happens with the part of the stomach that is sutured at endoscopic sleeve gastroplasty. I presume the question is, you know.
Yeah. So basically nothing. Of course, we screen patients for with biopsy of the antral region, familiar history for cancer, and so on. Nothing happens. We have now long-term data on this. The procedure is repeatable and reversible. When we see the stomach after suturing, it's like the stalactites, stalagmites formations. And this makes this gives also food transit slowing, and helps in losing weight and gives satiety. So basically nothing happens in the space in between the stomach, especially when it is attached wall to wall.
Thank you, Ivo. So here's an interesting question about robotic devices possibly replacing stitching. And if that were the case, how do you train with this new device?
Well, I have done this. We have done 17 so far of robotic devices, and I must admit this is a brand new sensation, because you go inside the stomach with the device, you remove the endoscope, you push a button, and then it works. It does everything alone. So we endoscopists are used to control everything, but and if suddenly the screen is shut down, it's panic, and then a robot takes over and is doing all the job, and you have these 30-40 seconds of waiting, probably less, and then you go again in and you see everything sutured. This is robotic endoscopy. It is doing the job for us. So will it replace all the rest? I don't know. We'll see. For the moment, it is quite promising, but I cannot say more. It seems it works very nicely. We'll see.
Okay, so I think maybe we have a minute for some kind of some more technical questions. I know it's kind of outside the remit of training, but I think we do have time. So we have a question from Batuhan, who has heard that endoscopic stitching can create a medium that food can enter but cannot go out from the sleeve portion of the stomach. So does this create a problem, and have you observed such a problem?
Never. So even if food goes there, the stomach simply is contracting, and it adds function to what we are performing. So it's not only restriction, as I said, it is also the transit time of the food that is alteration of the peristalsis, and it helps in performing of the procedure.
And there's also a question about endoscopic band ligation.
Yeah, I saw that.
For this, and what do you think? Is that a role?
Yeah, that has been published in Endoscopy, if I'm not wrong. somebody performed bending of the stomach, and there was also an image. I was impressed by that. This thing also alters the peristalsis, probably. It reduces some volume of the stomach, I'm convinced, and it gives alteration of the peristalsis. Could be in selected patients also should be tried, why not? We'll see. I mean, you see, it's a very, very impressive field. The past 9-10 years have brought many novelties. People are thinking how to solve these problems. The obesity is a very big problem.
Absolutely. So I think that we're coming to the end of the webinar. So I have a few slides to finish. And so just to say that everybody who has attended will receive an email with a link to complete so that you can receive your CME credit. So next slide, please. And a reminder about the early bird registration deadline for the ESGE Days 2020 in Prague. This is going to be a hybrid event, and we hope that we will be able to see you there. It is open for registration, and there's some fantastic live endoscopy that's going to be scheduled, lots of sessions over 3 days, international experts and hands-on training sessions if you do attend face-to-face with faculty members from 35 countries. So really pretty international, and make sure that you secure your early bird discounted registration. Next slide. And some benefits for ESGE members. My ESGE tutor is a learning module with lectures, cases, self-assessment, and you get a certification of completion for each module. And quality is also very important. There is an endoscopy quality check app, so use it to assess quality in your endoscopy unit. And just a reminder that the next ESGE webinar is on Wednesday, the 19th of January, and this is going to be a paper of the month from our journal called journal Endoscopy. And so this will be a groundbreaking paper papers that will be discussed. So be there. And so finally, I would like to thank our speakers, Ivo and Roberta, for marvelous presentations about how we can train in bariatric endoscopy. And also like to thank you, the audience, for giving up part of your evening to participate and for all your questions. Also like to thank the ESGE Governing Board for inviting us to be part of this webinar and for organizing this. And last but not least, the webinar team, David and Gabby, for organizing us, keeping us right, and for all your technical support. So have a very good evening, everybody. And thank you, and see you at the next webinar.
Thank you, Tony.
Thank you.
Thank you.